asked everybody last time I was here what field they were interested in since you weren't here. What field are you interested in?
Oncology.
Oncology. And surgical or medical?
I haven't decided yet, obviously, but either I'm interested in.
Okay, so it's two different fields.
Yeah.
How much more time should I give them?
I don't know, we could go ahead and get started.
Okay, all right. So one of the big things that has become a real issue in medicine is the issue of unconscious bias. I'm sure you've all heard of it, but when we started looking at it 15 years ago, Mass General Hospital actually did a study about unconscious bias, and they got just brutally beaten up by the Boston Globe for having, racist doctors. And yet the problem is that everybody's biased, and now it's become pretty well recognized that bias is a big issue. So this is the work I'm going to talk about today, is unconscious bias in the field of medicine. And then how I came up with a program using analytics to kind of come up with a way of identifying bias, both in the physician and the patient, which is, I don't think anybody's ever done before. Can we turn some of these lights down a little bit?
Absolutely.
Is it this one?
Mm-hmm.
So, you guys are young, but does anybody who know who that is? I don't even bother going back with Dr. Kildare. That's way too early. But that's Dr. Marcus Welby. It was a very popular show in the 60s, I think. And, of course, in those days, the doctors were all white males. Does anybody see a reason in that picture why you wouldn't want to see a TB doctor? Something wrong with that x-ray? It's upside down. So today, of course, things have changed. Our doctor population has become much more diverse in so many different ways. So it's changed a lot from the 50s and 60s. So unconscious bias, how does it affect things? In college sports, for example, they did a study that showed that white referees called more fouls on black players to the point that it actually affected the outcome of a game. And black referees did call more fouls on white players, but not near as much as the whites did on the black players. In Germany, there was an orchestra that had no women in the orchestra. And every year they would have auditions, and the women were, quote, never good enough to get in the orchestra. So one year, a woman applied to be in the orchestra, and she knew somebody on the selection board. And they said, well, that's not fair. We can't have some, like they haven't been practicing bias, right? So they decided to do the audition from behind a closed screen so nobody could see who was auditioning. And that year, not one, but 3 women got into the orchestra for the first time because the filter of bias was taken away. So since that time, all of the auditions have been through screens. So if you want to read a very depressing book when you get into medical school, this by Harriet Washington is horrifying. It's Medical Apartheid. And it's how they've been experimenting on blacks in this country for over 300 years. And not just blacks, but for example, the birth control pill was first tried out on Puerto Rican women. Poor people have often been used for test subjects. Prisoners are often used as test subjects. So this book talks about, if you want to read something that it's pretty depressing but very real, is read that book. I'm sure you can find it on Amazon. So how are stereotypes created? We're all bombarded with messages that are unconscious. So if you read this, I don't know if you can read it from the back, but here's an African-American man. This was after the hurricane hit New Orleans. A young man walks through chest-deep floodwater after looting a grocery store in New Orleans on Tuesday, August 30th, 2005. Here are 2 white people. 2 residents wade through chest-deep water after finding bread and soda from a local grocery store. So that he's stealing, and they're just surviving. And this is how we form our biases. We're constantly bombarded this from a very young age. And it has a big influence on how we see the world. Is anybody here familiar with the Iat Test? Okay. It was a test that was designed that they would put like an African-American face and a white person's face, and then you do word associations. And you were supposed to click on whether it was a positive or negative connection. So it might be like white, good, black, bad, and then they would switch it, black, good, white, bad. And what they did was they measured your reaction times online, and what they found is that they associated unconscious bias with slowing down the reaction time. You can actually go online and find this test. You can do it for African Americans, you can do it for obesity, you can do it for a number of subjects. It's got a lot of flaws to it, but it's something you can take a look at because it's kind of the first test that showed that bias existed. So how long does it take for bias to register, when you meet somebody for the first time? It's 115 milliseconds. That's all it takes before, when we meet somebody new, we actually register a reaction. And the reason I put this stranger thing up here is that in Kaiser, we used to have, we still do, our service scores are based on a number of parameters. One of them is this a patient that's seeing the doctor for the first time, or is it a return visit? And you can see, I'll show you a slide in a moment, it shows how the scores vary so much when it's a stranger visit versus a familiar visit. So if you don't think that you can't react in 115 milliseconds, has anybody ever done Tinder? You don't have to give it up, but how long does it take for people to swipe through 100 pictures? Yes, yes, no, yes, no. And they always put nice-looking people on their dating sites. There's eHarmony and I don't know what the Match.com. But it's all bias. I used to have a slide, I still do somewhere, and it's a picture of some males. And there's this one guy who's very handsome. And I asked the question, is this somebody that you would go out on a date with? And a lot of the women said, oh yeah, he's really cute, I'd go out with him. Well, he was the guy that strangled 23 co-eds at the University of Michigan back in the 60s. So, you just can't look at people and just know what's there. But that's what we do all the time. So here's the scores. We're not gonna need a whole hour for this. This is the scores for familiar visits for Kaiser. And it's a few years old, but it hasn't changed much. So here's pediatric scores, here's OBGYN scores, and here's medicine scores, and here's African American, Asian, Latino, other, and white. And you can see that this is based on thousands and thousands of visits. Look what happens when it comes to a first encounter, though. Look at how the scores drop in all three departments. Because when two people meet for the first time, what are they doing? They're judging each other. They're judging on their skin color, their gender, how they're dressed, they have tattoos. All these things kind of go into the mix in how we evaluate somebody. So when it comes to medicine, when I always work with the doctors, I always say, this is generally the area you have to work on and moving your scores up. It's that group there that we need to work on. I'm going to talk to you about how this whole project got started in just a few minutes. It was based on my own scores. So how does this impact us in medicine? There are more medical errors when you have bias. Inappropriate lab testing, either an absence of or too many. Longer length of stay. Lots of times people with bias end up staying in the hospital longer than they have to, or they're kicked out sooner than they should be. There's a higher readmission rate. In other words, for those people that got sent out of the hospital too soon, it's higher to be readmitted for African Americans than it is for whites. Quality metrics. There's huge swings between quality metrics between blacks, whites, Latinos and whites, and Asian and whites. Pay for performance metrics. More and more, when you go into medicine, your pay is going to be based on how well you do with your service scores, your quality metrics, and things like that. When I went into medicine back in the 70s, this wasn't an issue. Today, it's going to be a part of your life, particularly if you're in a large healthcare organization like Sutter or Kaiser or something like that. So gender medicine, how does it affect women? They found that Ambien, which is a popular medicine given for sleep, women were being overdosed. In other words, the amount needed for the average woman was 50% less than a man. So it was just knocking them out. Women are more likely to suffer chronic pain and less likely to be treated adequately. Physiologically, there's differences, not just the obvious ones, but a medicine will dissolve in a different part of the GI tract in women than it does in men. So if the testing for a pill has been done on men, and the pill dissolves in a different part of the body for a woman, it may not work as well, or not at all. Testing is often only done on men and not on women, so we don't know what the side effects are. We don't know what the efficacies are. Heart attack symptoms in women are, quote, atypical. Why? Because they don't seem the same as men's. So for men, typically severe radiating pain, crushing chest pain. In women, it may just be as subtle as indigestion type symptoms. These are the things that are going to kill people because doctors aren't trained to recognize the fact that biases exist in medicine. And heart attacks kill more women in the United States than all the cancers put together. It's a huge issue. And I've often had, women come in, they're worried about breast cancer and cervical cancer and things like that. And when I talk to them about things like metabolic syndrome, where they have a little bit of blood pressure, a little bit of diabetes, a little bit of cholesterol, they're a walking time bomb for a heart attack. And yet they say, well, I'd rather die of a heart attack than get cancer. But just because you have a heart attack doesn't mean you die. You can end up with a stroke, paralyzed, hemiplegia, things like that.
Question?
Yeah.
Do you know what the mechanism is for the women absorbing in a different part of the GI tract?
No, it's just a physiological fact. Yeah, I don't even know where in the GI tract it is. I have to look that out. So preterm labor and maternal mortality. This is a big issue. I'm sure you've seen the newspaper articles about maternal mortality. It's like 750 women died last year in childbirth. That's the number that died. It doesn't talk about the number of ones that had near misses, the ones that end up with hysterectomies because of postpartum hemorrhage. So you can see that for California here, Asians were 20, here's the baseline here for preterm labor. You can see the whites were almost 11% below the baseline. African Americans were 35% above. Asian were 6.5%. Native Americans, Inuits, Pacific Islanders, about 20% higher. So this is a big issue. Preterm labor, an average baby in the NICU is going to cost you $250,000. It's a huge issue. So Kaiser has a lot of data. They do mapping. So here's the Bay Area here. And what I found interesting about this is even though we know that blacks don't do as well with whites when it comes to preterm labor and maternal mortality, you see that there are areas here in the Bay Area where blacks actually do better than the whites do. So what I always look at data is you want to find out what the negatives are, but are there anything that's called bright spots? Is there things in the data where we should be asking the right questions about, well, why do people living in this area here do better than this area? Or this is the area I worked in, was Fremont, Hayward. This is San Francisco County. So you can see that we collect this data on deliveries, on cancers, on smoking, on obesity. All these parameters are studied by Kaiser. They have a very robust research department down in Oakland, and so they collect all this kind of data. So analytics, this is the area, this is why I came back to St. Mary's to get my MBA, was I was really interested in this field here. So this was on the cover of Times Magazine, and can you read what it says there? Hey, you're having a baby. Does everybody know about what happened here, what their analytics was all about? So by your shopping habits, they knew who was pregnant and their due date with a 90% accuracy rate. Which made it interesting for a man who went in one time to the Target store to talk to the manager and wanted to know why his teenage daughter was getting coupons for diapers. And he called back a few days later and found out what the problem was. So this is kind of stuff is being collected on you all the time, and it's getting more and more sophisticated. Amazon can pick out a book for you to read that you, with a better accuracy rate of liking it than you would probably pick out for yourself, just based on your shopping habits. It's pretty scary. Oh, come on.
I tried to surprise my husband with our second pregnancy, and he knew I was pregnant by what I brought home.
Yeah, really? If anybody has any questions, I know it's a huge audience here. Stop me. So how did this all start? I love this this is from 2002. When I joined Kaiser in 1979, there were no women in the OBGYN department. And when I retired 3 years ago, I was the only male left. A complete shift in the demographics of the staff for the department. And with that, a shift in what patients expected and who they wanted as a physician. So Kaiser sends out this MPS score. It's called the Member Patient Survey. And each doctor gets about 100 surveys per year. So this is something that if you go work for a large organization, I don't care what it is, Sutter or any of them, you're probably going to be hit with these things. So people are going to be asked to review you, and now they're going to review online and all kinds of places. So anyway, each doctor got about 100 surveys a year. Well, in 2003, my scores were dropping. And so my physician-in-chief, and I was chief of the department, said, you got to get your scores up. And I said, well, what do I do? And he said, oh, I don't know, but you just have to get your scores up. So then he said, and you have to hit a score of 78 point something. I go, where did that number come from? Well, that's the one we came up with. In other words, they didn't know what to tell me, but I just had to get my scores up. So I went home that night. I think I had a couple of bottles of wine. I was pretty depressed. And so I looked at my scores here, and I looked at it by age. Now, obviously, gender is not an issue because all my patients are women unless you get the rare man coming in for infertility. But when I looked at it by age, 18 to 34, 35 to 44, 45 to 64, and 65 plus, as the women's age got older, my scores got better. So that was kind of an aha moment for me. I realized that I didn't have to fix everything. I just had to fix this area here. So here's what was happening. I was getting a lot of young women who did not want to see a male doctor. And some of them for reasons I can understand. Maybe they were molested or raped. There's a lot of things that go into it. It's a very complex issue. But the bottom line is they didn't want to see me because I was a male. And I'd walk into the room. Hi, I'm Dr. Newhouse. Nice to meet you. I don't want to see you. You're a man. I didn't exactly want to see them either. And I'm sure all this unconscious negative vibes came back to them as well. So you can understand why my score was in the 30s down here for that age group. So I said, I don't have to fix everything. What I need to work on is that younger group of patients, basically 44 and younger. So working with my medical assistant, I said, okay, when I get somebody who's younger, you need to warn me. And sure enough, Karen would come in and say, okay, you're going to see a 20-year-old for the first time. Put on a happy face, shake their hand, be nice. And I'd go in and do everything possible to make that a great visit. I mean, answer every question. I would sit there forever, offer to wash their car, anything it might take to improve the visit score, and also their experience. And so that score went from 30-something to 96 the next time the scores came out. Now, I'd like to say I get a 90 every time, no, but it certainly went up on average to the 70s. I doubled my score just by being aware of this particular group and really spending extra effort. And so what I had was a targeted approach using analytics. And that gave me the idea of saying, well, that worked for me. I wonder if I could work with other doctors. So I went to the medicine department across the yard and did a presentation like this to the medicine doctors and said, would anybody be interested in letting me look at their scores and see if we can find a target area for you to work on and see if your scores got up. It was interesting. I had 13 doctors volunteer, 12 of them were women. The guys weren't interested. Another bias. The interesting thing was all their scores went up. And because so many of the doctors' scores went up, the department scores went up. And that's how my work started. So I started taking this around the region. I really worked in doctors in every specialty from allergy through urology, looking at their scores individually, doing coaching sessions, identifying the key areas for doctors to work on. Because what we do at Kaiser is that we do what some organizations do. If you had bad scores, we would send them off to charm school, which didn't work very well because they never focused on what the issues were. They would just tell them to be nicer, things like that. So they never looked at what the issues were. So I can give you an example of a doctor I worked with up in San Francisco. She was Chinese. She was from mainland China, and she was a specialist. And she was being sent to charm school every year, had gone 3 times already, and her scores never changed. So when I looked at her scores, she did very well with whites. She did very well with Latinos. She did very well with blacks. The only score she did poorly with was Chinese. So what was the problem? The problem was she was from China and spoke Mandarin. The predominant Chinese language in San Francisco is Cantonese. And there's a lot of bias between mainland Chinese people and people Chinese born in this country or from Taiwan. So once you recognize what the issue was, it made it a lot easier for her to try to work on her scores. Number one, having an interpreter there because they probably couldn't even understand her. So again, sending her to charm school was not the answer. It was identifying what the key demographic was. So what we started working on, I worked with Kaiser, is we started working on creating a data format here. I apologize if you can't see it, but this is familiarity, age, race, ethnicity, gender, how long the patient has been a member of Kaiser. Each doctor would get a trend line of 3 years of scores, get their 3-year average compared to the department 3-year average. And then you would get a plus minus here. So if you're a plus or minus 5 points to the department average, it was white. If you were more than 5 to 10 points negative, it was orange. If it was more than 5 to 10 points positive, it was blue. If it was more than 10 points negative, it was red. And if it was more than 10 points positive, it was green. So what the doctor now had was they could quickly look and see how well they did. So like this doctor here didn't do very well with young people. What's this one here? This doctor didn't do well with males. So you got a quick visual about where's your target area. And then I could make this even more micro. I mean, you're just seeing a part of the database. So I could tell you not just how well you did with Latinos, but how well you do with Latino women aged 18 to 34. I could get very, very nuanced because the closer your score gets to 100, the smaller the opportunity is going to get for possible improvement. So this was a second generation Indian doctor in my department. We did a number of focus groups in Kaiser, in my facility. We did Muslim women, patients from India, Chinese, young adults. When we did our focus group, what doctors do you think patients from India didn't want to see?
Indian?
Indians, but not just any Indian doctors. It was the second generation Indian doctors. It was the FOBs versus the ABCDs. It was the fresh off the boats versus the American-born confused Doisies, they call it. So this doctor here is a Doisy, and she did really well with Chinese, even better with Filipino, spoke Spanish, so she got 90% with Latinos, did very well with whites. The only group she didn't do well with were people from India. And when I asked her about it, I said, well, what's going on? She said, well, they drive me crazy. Well, if they drive you crazy, you're going to have a hard time having a good relationship with your patients. And basically, it comes down to, for a lot of these doctors, either they just have to learn to like those patients, whereas some doctors actually did, they would actually transfer to areas where they had demographics that they could feel more comfortable with. We were actually losing a lot of our Chinese doctors out of Fremont. They were going to other Kaisers where there were no Chinese patients. So here's an example. Here's a doctor. It's a male doctor, department of medicine. And you can see that, you know, basically the scores aren't bad. They're about 3 points below the department average. 84 for men, 81 for women. Well, look what happens when you break it out by familiarity. Look what falls out here. Women for the first visit. Scores drop down to as low as 29 there, but a 51 average and a 62 for men. So this doctor really needed to work particularly on his visits with women meeting for the first time. So this was impacting our doctors' pay raises, bonuses. It was impacting partnership, physician morale, because you get very depressed when you're told you're not a very good doctor. And it was hurting our physician retention because we were losing doctors. They were either transferring or some weren't making partner. So I know you're a long ways from working as a doctor yet, but tuck this away in your memory banks because I can tell you 10 years from now, this is still going to be an issue, particularly for the women, or if you're a doctor of color. It's a really big issue. So here's a doctor. I mean, it's very easy. This is the kind of doctor we wanted. right? If you look at that, all blues and greens. This is a very high-performing doctor. This is kind of, when I was chief, this is the kind of doctor I wanted. Unfortunately, sometimes I got doctors like this. And yet this doctor was quoted up for partnership as being a high performer in service. But look at that. It's just, all you have to look is the column here. It's just all red. It wasn't anybody this doctor did well with. Probably should have been a pathologist. So here's an example of how the scores can affect you. So this is me when I'm a lot younger. This is a friend of mine, Winnie Tum. I'm going to ask her if she's willing to come. She's a pediatrician. So what I took was, I'm going to create a scenario here. We have two medicine doctors with identical regional scores. In other words, I'm going to give them exactly the same scores for Chinese patients that are seeing for the return visits, return whites, first-time Chinese visits, and first-time white visits. Now, Winnie, she's a young doctor, being brand new, is going to have mostly what? New patients, right? She's got to build up her practice. So I gave her 80% stranger and 20% familiar. Being Mandarin speaking, she's going to attract a lot of Chinese patients. So I gave her 70% Chinese, this is pretty typical, and 30% white. Me having been there for 30 years, I'm going to have mostly returns, some stranger, I'm going to have mostly whites, and a few Chinese. Okay, same scores, different ratios. So what's different are the ratios of who they're seeing. So my score comes in at 80%. Her score comes in at 64%. And if you take it out by gender, the gap gets even bigger because women mark, in Kaiser at least, 6 to 8 points lower than men in every department except psychiatry. So if you're a white male in Marin County with an old white population, you don't have to work very hard at making your patients happy. You already have a built-in demographic. But if you're a young Mandarin-speaking female, you've got a tough road to go in getting good scores. And nobody even thought about this until I brought it up. Like in my department, here was a young Chinese doctor. Her scores were here. They were in the 50s. And our physician-in-chief at the time wasn't going to let her make partnership because, quote, we weren't going to have any low-performing doctors. So the chief of the department at the time came to me and said, Dave, how do we make the case that she should make partner? I said, well, look at her return visit rate. It was skyrocketing. In other words, once the patient saw her, they were coming back to see her over the next 3 years. So I said, if they didn't like her, they wouldn't be coming back to see her. So based on that, she made partnership. Scores kept going up. This was the year she got sick, was out for a while. That had an effect on 1/4 of her scores. So she had a little dip. But look at her scores now. Very high-performing doctor. A bilingual Chinese-speaking doctor that we critically needed in Fremont almost didn't make partnership because we didn't understand the scores. And they're working twice as hard because they don't have a medical assistant to do their callbacks for them in Chinese. They don't have translated materials. In other words, they're doing a lot of extra work than the mono English-speaking doctors are. And yet they were getting dinged on pay raises, bonuses, and partnership. So this was a lot of the work I was doing, is really helping to not have bias against our doctors of color and our female doctors in medicine. So again, 10 years from now, you're going to run into bias all throughout your career in medicine in a lot of different ways. This was a doctor, specialist, female, and she had good scores with African American and with Latinos. She had low scores with Chinese, and relatively low scores with whites. So she had two different issues going on here. The Chinese patients really liked her. They were bringing her gifts and things like that. But the Chinese patients culturally marked lower. Plus our survey instrument said the high score you could get was excellent. There's no word for excellent in Chinese, so they didn't even know what the word meant. So the whites, on the other hand, didn't trust her because she was from another country. Their bias was, well, I want an American-trained doctor, even though she had gone to or done her residency at one of the top, residency programs in the country. So for my advice for people like her was, put all your diplomas up there, show where you trained, talk about your training. For your Chinese patients, you need to let them know how important the survey tool is. And that if you really do like them as a doctor, then you need to mark appropriately or it really hurts them. And so she was able to bring her scores up with both these groups by taking two different strategies. But once she knew where the gaps were, she was able to come up with strategies to apply to both. You never know what kind of biases you're going to get into. I talked to one doctor, she was from India, and she had a lot of her Indian patients were mad at her because she was married to a white man. And she had her family pictures up, and she finally had to take her family pictures down because it got so bad. So you just never know what kind of issues people are going to run into. So, all right, so let me get, since you guys, see if you can figure this out. This is an orthopedic surgeon. You're going to try to guess what the issues are and what is the gender and race of this doctor. Okay, so this is an orthopedic surgeon. What do you see up there? African American, low, right? Okay. Other, wherever other is. Female. I mean, those are the two that kind of stick out. So one of the things that I always like to tell people is when you have data, try to break it down even further. Just go even lower into trying to put it under the microscope and break it out even further. So now we broke it out by female African American, female Chinese, female Filipino, female, male, 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 male. Now what do you see? What's the issue? Yeah, it's women. It's women. Look at, you can just, it's so clear. It does really well with African American men, had a 93, 100, 97. White male, 77, 98, 75 overall. I mean, it's so clear this doctor does so much better with men than with women. Even no matter what their race and ethnic group. So anyway, what race do you think this doctor is?
African American male.
Nope.
White male.
Closer. It's a white female. In other words, you can't tell, really, how different doctors are going to relate to different patients. It's really interesting. I used to ask doctors when I'd coach them, I'd say, who do you think you do well with? And who do you think you have a problem with? It was very rare that they knew where their problem was. Most of the time, we don't know our biases. We don't understand how people perceive us. And this is the beauty of data, is it's neutral. So I had one Asian doctor come up to me and say, oh, okay, I heard you talk. The reason I'm not doing well is because I have a lot of Chinese patients. No, it wasn't that. It was she was doing lower than the department average for Chinese patients. She just wasn't doing well, period. So it takes the excuses away as well. Yeah.
Oh, how do you, like, statistics-wise, how do you account for, like, the bias of the actual patient answering these survey questions?
You can't. What I look, you can't. So first of all, I had three statisticians argue with me from the audience about why this would never work. In other words, there's no statistical significance. How do you do something with 3 surveys a year, for example? What I look for is patterns. So when I see a doctor year after year after year, does low, that to me shows a pattern. So I worked with one doctor. She was from India, female medicine doctor. And she did well with every group except African American. Now in Fremont, our African American population is 3%. And so if you get 100 surveys a year, you're gonna get about 3 surveys a year. Even though it was only 3 surveys a year, year after year after year, she was consistently, that was the one outlier. So I said, look, why don't you just focus on your African American patients, spend more time, make sure you use Mr. or Miss, I mean, don't call them by their first name, let me go, that's a whole other thing, use some cultural competence here. It took a whole year to get 3 surveys back, but that was the first year she moved her scores up and that score went up with it. So what I look for is pattern recognition. That's how this works. I'd like to get somebody to work with me on doing, we can crunch it through the analyzer and get statistical significance. But you can, over time, when you look at large groups, Chinese-speaking Chinese were the lowest scoring group in the region. English-speaking Chinese were next lowest. Whites were the highest scoring, followed by blacks, followed by Asians, or followed by Latinos, followed by Asians. So yeah,
Do the questions in the surveys change every year, or like
same thing.
are they like
These go back to 1992.
okay? Are they worded like in specific ways? Like have you looked at like the wording of
Yeah, we
them?
had to change the Chinese ones. Once we realized that it was translated incorrectly, they finally changed the form because it was just killing the Chinese doctors. So yeah, if we find a mistake, we try to correct for it. I'm not going to say that the survey tool is perfect. It's not, but we get 1.5 million of these surveys every year. So the numbers I had to work with really was very impressive. The other thing was it was also dinging our facilities. Everybody was very competitive about which facility had the highest score. Well, it turned out to be San Rafael, North Sacramento, places like San Francisco, Hayward, Fremont. We came in at the bottom. Why? Because it's like going back to that doctor. We had different demographics. So when I showed that, the people that were at the facilities that have white populations got mad, and I said, I'm not taking anything away from you. You guys have good scores, but you have to realize you don't have to work on having interpreter services and things like that, like other facilities do. And once you readjust, I took that slide out, maybe I should put it back. When you readjust, it's amazing how the rankings have shifted. Same thing with doctors. We still rank doctors in Kaiser, out of 1,000 medical doctors, are you number 384, you're 922. It's worthless information. It's actually demoralizing because it's really hurting our doctors of color and our female doctors. Did that answer it? Or?
Yeah, no.
Okay, so here's an African-American doctor, a good friend of mine. When you look at his scores for return white women visits, scores were high. But look what happened when he was seeing a white woman for the first time. Every other group he scored in the 90s with. So I just made this graph simple. Look what happened when he identified what the problem was. And it was interesting when I talked to white women about this, patients, oftentimes it wasn't they had the problem seeing an African-American doctor, it was their husbands. So this is the kinds of biases you can get into. So anyway, summary. We do targeted interventions. What I found is that awareness was the first step. Once you know where your gap is, it's amazing. It's 90% of the battle. And not every issue was race bias. So I worked with 5 urologists, and they worked part-time in Hayward and part-time in Fremont. Now, most of your patients, 80% of your patients in urology are men. Most of them are men over 60. So what's a big issue for older men is prostate cancer, things like that. So same doctors, 5 doctors, all of them had a 20-point drop when they went from Hayward to Fremont. So to me, that's not a doctor issue, that's a system issue. So I interviewed all the doctors, and it turned out that in Hayward, if a 70-year-old man came in and they were suspicious about prostate cancer, they could do an ultrasound right there in the department. They didn't have an ultrasound machine in Fremont. So you're 75 years old, you're frail, your 70-year-old wife had to drive you in. Now they've got to book another appointment to go be seen in Hayward. We got an ultrasound machine for Fremont, and the scores became identical. So that was an example of using the data to actually find a system issue. There was a chief of a small department, I think it was allergy, three people, 2 doctors and a nurse, nurse practitioner. He didn't like his nurse practitioner because she had, quote, low scores. She was scoring in the high 80s and he was in the high 90s. But when I looked at her demographics, she was seeing all the first-time visitors, patients. And I pointed out to him, she's actually doing better than you are with first encounter. She has 90% first-time encounter. Once he realized that, it totally changed his perception of his nurse practitioner just by having some data. And that's what data does. It shows you what's going on. So I'm going to end on a positive note here. This woman has albinism, and this is Rick Guidotti down here. So he was a famous photographer for like Vogue magazine. He was doing pictures of Heidi Klum and all kinds of famous models. And he was walking down the street in New York one day, and she went walking by. She was all slouched over. And he looked at her and he said, "Wow, she's really striking. She's beautiful." So he runs up to her. He says, "I want to take your picture." But she thought, "Who's this weirdo, coming up to me in the street in New York?" Well, somehow he convinced her that he really wanted to treat her like a model and take her picture in a professional studio. And she agreed to do it. And this is her modeling pictures. And so what he saw was the beauty in her. And she totally changed her outlook. And he quit doing photography. The name of his company, if you want to Google it, it's called Positive Image. So he now goes around the country. So for example, say your baby has a cleft palate, or you have Marfan syndrome, or a lot of, all kinds of things. He goes around and photographs these children in a positive way. And families contact him to get pictures taken of their children. And it's an amazing, he's also done a TED Talk. If you want to see an amazing TED Talk, his name is Rick Guidotti, G-U-I-D-D, or you just do Positive Image probably. Just an amazing person. I heard him give a talk, and he's just dynamite. So everyone is a prisoner of their own experiences. Nobody can eliminate prejudices. Just recognize them. Edward Murrow. So I got some good news. So this is Dr. Calvin Wheeler. He is a pediatric neurologist. He was my boss. He's still working. He works with Kaiser down in Oakland now, the main headquarters. Once you hit 65, you term out as physician-in-chief in Kaiser. So he's also has a lot to do with the new medical school that's going up, in Southern California. So he's agreed to come and give a talk or answer questions. So he's the first one I'd be able to ask, have him come and give a talk about anything you want to hear about. So what I'll need to do is figure out, a time and place, and I'm hoping that, we're going to get a better turnout. I hate to have somebody like Calvin come and then have 5 people show up. I think everybody would benefit. And I'm going to be going to our medical center's holiday parties coming up in 2 weeks. And I'm going to be talking to a number of people there. There's a friend of mine who's an ER doctor who also, when 9/11 went, he does disaster relief as an emergency room physician. I think he'd be worth listening to. And then I'm going to look for some of the specialists that you guys brought up last week. An orthopedic surgeon, for example. I'm just going to ask everybody if I can get a panel discussion going. So that's my talk. If you found it interesting. Any other questions? Yeah.
What are some things that I guess we could do now to start being more aware and working on our unconscious bias?
I can take the Iat Test for one. I can do that.
Can we look at your first slide of the talk again?
That one?
Next one. With the chart, the first one with the chart.
Stop me where.
I guess it wasn't the first one. The first data one.
That one?
Yes. So that's saying it's the ethnicity of the patients on the x-axis.
Yeah, race, ethnicity.
Uh-huh. And so, what about this issue with women? I mean, are they just harder scorers in general? Is that your...
I think women have, there's I could spend a whole talk on women's issues. In fact, I wanted to write a book for men. My years of working with women, my advice. But anyway, I think many of your women are more invested in their health care than men are. I think a lot of guys just want, and I've talked to female internal medicine doctors, and I could show you slides where the patients, women doctors hated to see the most were women. Because number one is they have more questions. They're more likely to go do a Google search and come in with piles of information. 3, their expectation for women doctors is higher than men. I had a complaint against one of my female doctors in the department. The woman said, look, I don't expect a man doctor to get me. They're just stupid. But when I see a female doctor, I expect better. And so that was the bottom line. So I think your expectations as women are higher for women doctors. And I think that your investment in your healthcare is a lot greater. And it's usually the women who end up bringing their husbands in for healthcare. I mean, my ex-wife was an ICU nurse before she became a nurse midwife. And she had a patient come in the ICU who was close to death and was ready to pass on. Her husband had a heart attack. She literally got better long enough to go take care of her husband. When he died, then she died. I mean it's just an amazing story. So you see things like this, and it just blows your mind. There's a lot of things about medicine we don't understand. Oh, by the way, getting back to 2000, the other thing I did in 2000 was I learned acupuncture. Because 70% of women, I saw a survey that said 70% of women prefer a doctor who knows something about complementary medicine, so I became a trained acupuncturist as well. And I put that on my website, and I had a lot of patients come see me for acupuncture. In fact, 40% of my patient panel was probably acupuncture patients compared to regular GYN. So I blended allopathic and complementary medicine. It's something to think about in the future too. I know your first gen is get through med school, but there's other types of medicine as well that are very interesting. Any other questions or, yeah?
Have you looked at how patient ratings impact like the actual outcomes, the patient outcomes?
That's a great question. Nobody that I know of has ever tied service scores and quality metrics. We believe it has a big impact. A lot of African Americans, for good reason, when you read the book Medical Apartheid, do not trust the health system in this country, and I don't blame them. But if you don't trust it, then how likely are you to follow your doctor's advice if you don't believe in the advice they're giving you? So it has a big issue. But nobody's ever taken the two systems of quality metrics and service metrics and matched them up. I tried to get Kaiser to do that, and nobody's done it yet. But I think it's maybe you guys will get it done. But that's a great question. But we know it has an impact. We know that African American males hitting the emergency room with a broken bone are much less likely to get pain medication than a white patient is. Women having chest pain are less likely to be treated properly than males are. It just goes on and on and on. African American men are less likely to be treated for having a cabbage procedure for blocked heart valve than a white patient is. It just goes on and on and on.
So my understanding is that people who are treated by somebody with their same race ethnicity have received better care. I've seen some data about that. So did you all come across that, and do you all make it, or did Kaiser make an effort to match race ethnicity, or?
It's pretty hard, and it doesn't always work because, go back to this doctor here, he didn't want to see Indian patients.
Right. I mean, this challenges that.
I talked to Kaiser has a big diversity conference every year, and when we still had our Ohio region, there was a large African American population in Ohio, and they had a problem with their African American doctors having very low scores with the poor blacks that came in across the river, a certain section of Cleveland. So just because you match doesn't always guarantee that you're going to get good results either. In general, yes, but doesn't guarantee it. Again, going back to the Chinese doctor who was Chinese, but she spoke Mandarin and not Cantonese, and she was from mainland China, not born in this country. So all kinds of biases. That's what I don't know if you know, familiar with the Institute of the Future, Bob Johansson, great speaker. He's over here in Palo Alto. He talks about full spectrum thinking. And I think that the way we need to look at diversity, and even that word's going out of vogue now, it's cultural awareness, is that it's not just, like I looked at one department, I'll give you an example, pediatrics. The one score they did low in was black teenagers. Not blacks, but just that age group. So we need to sometimes take that data and keep refining it. find out where's the gap, where's the training need to go. Then you can talk about bias training once you have where your gap is. So I call that full spectrum thinking. Yeah, I've got, as I think about it, I got hundreds of examples. I got to meet hundreds of doctors over the years, interviewing them and hearing about their issues and things like that. Each doctor is unique, each patient's unique. Bottom line is, how do we provide the care that that patient's looking for, and how do we take care of our doctors so they're able to give the care they want to give? We did a survey on employee satisfaction, and that was very interesting too, especially the one on how long they'd worked in Kaiser. So it was like a big U. So if you were just starting out, you had high satisfaction working for Kaiser. If you were in 15 years, you were down here. And if you're about to retire, you were happy again. So, anyway, hopefully that's not going to be you guys. The other thing that's interesting too is that when we test, not Kaiser, but when tests have been done on medical students, they have very high levels of awareness of cultural issues. And when they come out after their residency, it's been all kicked out of them. They're all beat up. And their cultural tolerance is really low. Because when you're tired, you're fatigued, you've worked all night, that's when your biases are going to be more likely to show up. I had a patient not last year, a few years ago, many years ago. I was on call, 2 a.m. I get a call from Oakland saying that their beds were full. They needed to transfer a patient to me with tubal ovarian abscesses where you have a massive infection in the pelvis. I said, fine, at least do the workup, do the physical exam and write some orders. Well, the patient comes transferred in. She's alcoholic, high fever, no orders have been written, no physical exam. I have a busy labor and delivery. I was not a very happy camper, I'll be quite honest. And this is probably the third or fourth time this woman had abscesses like this, and she was about 40-ish. And I was going to discharge her, transfer her back to Oakland the next day, but I kind of felt like she'd gotten a runaround. So I said, look, you really need to have a hysterectomy. You need to have this all taken out because you're just going to keep coming back with one infection after another. And one of these days it might even kill you. So she agreed to it. I did her surgery. Everything went fine. She went home in 3 days. That was the end of that, right? I thought. Years later, this woman shows up, well-dressed. It was her. After doing the hysterectomy, her pain went away. She joined AA. She cleaned up as far as gotten away from her alcoholism, got a job, and she had taken Bart down from Richmond just to thank me for doing that surgery. So you never know. When you're tired, try to think about, don't let those biases get in your way because it can lead to medical errors, all kinds of issues. I can't tell you how many times I've seen things go bad in labor and delivery because of potential bias. Things get ignored, missed, things like that. So it's something that's not going to go away, this whole topic. I don't want to put a downer on it, but fortunately, people will find you. You'll have a certain group of people that you guys will match up. And those are your patients that you'll be with. Like for me, I had patients going back 35 years. Some of the babies I delivered their babies. And I wasn't sticking around for the babies, so it was time to call it quits. Any other questions? Or like I said, if anybody has a question, you can always shoot me an email or whatever. I'm not going to be able to make next Wednesday. I have to fly back to Michigan. My sister is very ill, and so I'm going to be gone next week. I don't know when you guys want to try to set up another this time, or you want to try to set up